اسكندريه. تشرفنا كتشير بيرسون ان شاء الله، وانا الدكتور احمد منيب. هنبتدي اول توك هتبقى الدكتوره مها عمر باسم Body Imaging Interesting Cases. اتفضلي دكتوره مها.
Okay. Good afternoon, chairpersons, dear professors, valued guests, and colleagues. First, I would like to welcome you all on our annual Radiology Scientific Conference, and specifically in our body imaging session today. Second, I would like to thank the organizing committee for this wonderful and well-organized execution of such a huge scientific event. I'm sure they all put great effort and time into this. Finally, I would like to express my honor and gratitude for not only being part of this session today, but also for having the opportunity to welcome you all in the beginning of it. I am Maha Omar, radiology lecturer of Body Imaging Group in Ain Shams University, and today I'm going to present only very few interesting cases of the huge diversity we see every day working in our university hospitals as tertiary centers. Let's start with case number 1. He is a 46-year-old male patient presenting with lower abdominal pain and melena. The patient underwent MRI of the abdomen and pelvis with IV contrast. I'm going to present only the pelvic sequences because they have the findings. This is the axial diffusion weighted images. The ADC images, the sagittal T2 images, coronal T2 images, axial T2, axial T1, pre-contrast, and axial T1 post-contrast fat-sat images. So, what is the origin of this pelvic mass? Actually, many of you may say it is originating from the rectosigmoid junctions or the upper rectum. On the contrary, if you look closely at the previous images, this will help you to determine the actual location of this mass, which is the distal ileum or the small bowel. So, let's have a closer look. As we can see here in the diffusion weighted images, we have a pelvic mass that has true diffusion restriction. In the T2 images, the axial, the coronal, and this is coronal images of the same lesion. We can see this lesion originating from the distal ileal bowel lobe here as an endophytic component and a larger exophytic component. This is also can be seen here. This is the endophytic component and the larger exophytic component. And there is mild proximal dilatation of the distal ileal bowel lobe seen here. This lesion is well-defined, has well-defined edges and cystic and areas of cystic degeneration. It has more or less homogeneous post-contrast enhancement apart from the small cystic areas. The lesion, the patient underwent surgical excision of the lesion, and the histopathology was small bowel guest tumor. So, the differential diagnosis of small bowel tumors include adenocarcinoma, lymphoma, carcinoid tumors, and guest tumors. This table explains in short the terms of differentiation between them regarding the location, the key imaging features, and the enhancement pattern. As we can see here, for adenocarcinoma, the most common location is the duodenum, followed by the jejunum, then the ileum. It is presented mainly as focal circumferential mass with shouldered borders, as in this image. As for lymphoma, the most common location is the terminal ileum, and it is presented mainly as thick wall infiltrating mass with aneurysmal dilatation of the small bowel loops. As for carcinoid tumors, the most common location is the distal ileum, followed by the appendix, and it is presented as hypervascular mass, mainly seen in the mesentery, not in the small bowel. It can be associated with bowel wall thickening and surrounding severe desmoplastic reaction. And in our case, guest is a well-defined, mainly exophytic mass, but can be presented, as in our case, as endophytic and exophytic mass. The most common location is the stomach, followed by the small bowel, as in our case. So our take-home message is careful assessment of the lesion in various planes is essential to determine the origin and extension. The commonest GIT location of guest tumors is the stomach, followed by the small bowel. The endophytic-exophytic growth pattern is common in guest tumors. Diagnosis of malignant guest in absence of metastatic deposits requires only histopathological analysis. Case number 2. She's a 22-year-old female patient presenting with recurrent attacks of hematemesis and melena. CT mesenteric angiography was performed to assess for melena, and this is the pre-contrast phase. Okay, this is the arterial phase. The portovenous phase. So let's have a closer look at the findings in our case. We have a lesion that is inseparable from the upper jejunal bowel loops on the left side of the upper abdomen. This lesion shows intense arterial enhancement that is close to following the blood pool in all phases, and similarly in the portovenous phase, here on the right side of the screen. This is a MIP image, reconstruction images of the arterial tree in the arterial phase of the CT mesenteric angiography, showing this lesion to be intensely enhancing in the arterial phase with a branch supplying it from, that is originating from the superior mesenteric artery, which is also evident here. The lesion has an arterial branch supplying it, which is originating from the superior mesenteric artery, as I said, and it also has early venous filling in the arterial phase through its venous drainage. It will be evident in the next images. Yes, here. This also coronal MIP image in the arterial phase and coronal MIP image in the venous phase, demonstrating the supplying artery of the lesion, which is a branch of the superior mesenteric artery, and the draining phase, which is also evident in the arterial phase and here in the venous phase, which is a branch of the superior mesenteric vein. So final diagnosis of this case is mesenteric or jejunal arteriovenous malformation. This was confirmed angiographically, and the lesion was managed accordingly. The patient, was managed accordingly. An important complication of such lesions is the Steele syndrome. Why the Steele? And let me highlight this complication for you. This lesions has high blood flow, which can result in shifting of the blood from the arterial to the venous side, hindering a proper vascularization of the bowel and resulting in bowel ischemia, which should be looked for and reported in such lesions. Here is a case published online for an arteriovenous malformation, a mesenteric arteriovenous malformation with resulting bowel ischemia, evident here by thickening and hypoenhancement of the wall. Another case here, these are the vessels. It is an inferior mesenteric vascular malformation resulting in ischemic large bowel, mainly the descending colon, which is the territory of the inferior mesenteric artery. So let me also have this opportunity to mention the most important items that need to be fulfilled as a checklist when reporting arteriovenous malformations anywhere in the body. We should report the size and the site of the lesion exactly, defining and localizing the nidus, which is the collection of the deformed vessels in the center of the lesion. Define the feeding artery and the draining vein, number of feeding arteries, which may be more than one, and the origin of such arteries and the drainage, the venous drainage of the lesions to help guide the management. We should also look for aneurysmal dilatation in the feeding artery and report it if present and the size of this aneurysm, and any possible complications such as ischemia, as we said, the Steele phenomenon, bleeding, rupture, and so on. So our take-home message: small bowel mesenteric arteriovascular malformations are less common but represent up to 75% of obscure GI bleeding. CT angiography has high sensitivity in detection and diagnosis of mesenteric bowel or small bowel arteriovascular malformations. Steele syndrome and bowel ischemia is as important complication to look for. Treatment options for symptomatic cases include endoscopic interventions and angiographic therapy, for example, embolization and intraarterial vasopressin. Okay, case number 3, it will be quick, highlighting an important points for junior radiologists, especially in the emergency setting. The patient is 19-year-old male, presented with abdominal pain and hematuria following road traffic accident. Multiphasic CT of the abdomen and pelvis with IV contrast was performed. These are the pre-contrast images. As we can see here, we have a hyperdense small parenchymal left renal lesion, which is likely a small hematoma in the setting of trauma. We also have this hematoma in the left rectospinal muscles and the paravertebral muscles, which extend to the retroperitoneal. This component is retroperitoneal. These are the pre-contrast images, no contrast here. This is an arterial MIP images of the left renal artery, which is essential to look for in the imaging setting of renal trauma. We should examine the arteries and veins carefully for any evidence of arterial or venous injury. Here, the left renal artery is intact, no signs of extravasation or injury. The same here, this is the left renal vein, and this is a coronal MIP image of the venous phase. This is the portovenous phase, and this is the delayed phase. We have renal laceration that extends to the upper calyx here, okay? This laceration also has an extension in the perinephric space, in the posterior perinephric space. It is essential in the renal trauma to look in the delayed phase to search for evidence of calyceal or I only have 1 minute. To search for calyceal or collecting system injury, as we have here, there is extravasation of contrast in the delayed phase indicating calyceal injury. And this contrast is extravasating and collecting in this collection. So, this is also the delayed phase with the contrast filling this collection. So the final diagnosis is grade 4 left kidney laceration injury with intraparenchymal small hematoma. Let me also have this opportunity to show you the renal injury scale according to the AAST, the American Association of Surgery and Trauma. And in this case, the grade of the injury is grade 4, laceration extending through the renal cortex, medulla, and into the collecting system with injury of the collecting system. So our take-home message: assessment of images in the setting of trauma is mandatory to visualize hematomas. Multiphasic CT studies essential in the setting of major trauma to localize, identify, and grade the degree of solid organ and vascular injury. Delayed phase of imaging is especially important in renal injury to assess calyceal or collecting system injury and urine leak, which change the grade of injury. Accurate grading of solid organ injury in trauma patients is essential in guiding further management plans. Thank you.
شكرا جزيلا. بس يعني اللي بعد كده من فضلكم يا جماعه we have to respect the time. عندنا حالات كتير جدا جدا جدا. دكتوره مها, very nice presentation.